All right. All right. Well, thanks for the announcement, Zoom. So, all right, we're on. So thank you. Thank you so much for your time and so excited to talk about all things perimenopause with you. But when it comes to perimenopause, I feel like, getting the basic right is like super important. So want to start with you. Just first tell us a little bit briefly about your background. Like that would be helpful.
Sure. Yeah, it's so nice to be with you. So my name's Lylen Ferris. I am a naturopathic physician, and I attended the National University of Natural Medicine, which is in Portland, Oregon. And this is an accredited naturopathic medical school. There are only a handful of accredited schools in the United States and Canada. And essentially what that means when you're trying to choose a practitioner is if a naturopathic doc has attended an accredited school, it means we get really the curriculum a conventional doc would get plus. So we rotate through lots of things. We do minor surgery. We learn all these different modalities, and that's our training. So we're in the classroom. We spend time with patients, and some of us do residencies. I was lucky enough to do a residency in women's health. And since I was released from that residency, I've been focusing on hormone health and all of the different ways it can affect us from, the different cycles in our life. Sort of it's starting with puberty, then it goes through what we might call our fertile years, and then things start to change. What we're here to talk about today, perimenopause, and then moving into menopause. So that is a big focus of my practice, and it's important to me because I'm in that phase myself.
That's awesome. So what is perimenopause and how is it different from menopause? Because there are so much narrative out there that kind of combines peri and menopause together. And while that's not completely wrong, because that's a whole sort of entire phase of women's life, they're so important, but we'd love to just help, our audience, like, what's the distinction?
Yeah, no, it's a great question. And to be honest with you, I think a lot of people don't really quite know what perimenopause means. So let's start by talking actually about menopause. What does menopause mean? So the definition of menopause is um, 12 consecutive months without having a period. So if you had your period on January 1st, 2023, and by January 1st, 2024, you had not bled again, you would technically be in menopause. If you had your period on January 1st, 2023, and then you had another period on December 1st, 2023, unfortunately, you have to start all over from day one. You're not in menopause. But when we talk about perimenopause, that's really all the years leading up to this transition. So in perimenopause, what happens is your body begins making less and less of the hormones that control your period. And we're talking about estrogen and progesterone. So the average age of menopause in the United States is 51, but because there's a vast difference in the age at which women reach menopause, this means that the normal range of menopause in the United States is actually age 40 to age 58. And because the physical changes that lead to menopause can begin anywhere from 4 to 8 years before menopause, that means we could be looking at the perimenopausal changes starting at age 32 in some women. Now, these are outliers, but I think 35 to 40 is a pretty predictable time by which we may start to see changes in the way our estrogen and progesterone is being secreted. This is perimenopause, and it can affect the way we feel in so many different ways.
Mm-hmm. Yeah, that's just fascinating. And I think that's also what I ended up getting into Nabi project because it really starts much younger than we all think. And it's shocking for a lot of women, and
Yeah.
myself included. I was that person. But every time I threw that like in mid 30 and everybody's like, wow. So that is the truth, ladies. So one of the things that as I'm working on Navi, I meet a lot of women and start talking about this perimenopause. And the first question is like, how do you know? How do you know, what are some of the sort of indicators or what are the things that I could check? These are the kind of common questions. So would love to hear from your perspective, kind of what will be the sort of good starting point for someone to start paying attention to what may be perimenopause as a
Yeah.
start?
Yeah. I appreciate you asking the question, but the answer is actually complicated. It can actually be really difficult to tell because every woman's experience of perimenopause is different. Now, for some women, they're not going to experience any physical changes during perimenopause, except maybe some irregularity to their menstrual periods, and then their periods just stop. Now, we love these women, but we may secretly hate them too, because most of us actually do have a lot of symptoms in the perimenopausal transition. Now, this can happen gradually and subtly. So you may not realize at first that these various symptoms that you're experiencing are actually related to the same thing, which is hormonal fluctuations that are associated with perimenopause. We know that changes in estrogen and progesterone drive this transition. So I'm just going to start to list some of the common symptoms that women might experience. And EJ, feel free to jump in at any point if you want to ask me some follow-up questions.
Okay.
So the first thing is irregular periods. As our ovulation becomes more unpredictable, the length of time between your periods could get longer or shorter. Your flow can change. It can get lighter or it can get heavier, and you may start to skip some periods. Now, this can look a lot of different ways. You might see periods so 28 days between periods is textbook. Your periods might start to be 21 days apart, or they could start to be 60 days apart. There's a lot of variability in how that can change. Maybe you used to bleed for 3 or 4 days, but now suddenly you're bleeding for 5 to 7. Maybe you miss a period and you start to feel some swelling and discomfort in your pelvic area when those periods are missed. Or maybe you have a lot of spotting between your periods. So maybe your periods are even textbook regular, but you're starting to have some spotting in between. And also, maybe you're having more pain or a heavier cycle. So if you notice that you're using more tampons or more pads than you used to, that can also be a sign that these hormones are changing. And the way that we notice that primarily is because our menstrual cycles change. This is especially noticeable for people who have had a regular cycle. If you're one of those women who has never really had a regular cycle, it can be harder to track it this way. I do want to sort of caution all of you, as ovulation becomes less regular, your ability to conceive decreases. But if you are still having periods, you can still get pregnant. If you don't want to get pregnant and it's only been 10 months since your last period, please continue to use contraception, because I think there's a lot of oopsies in women in their 40s when maybe they thought they weren't so fertile anymore, and you certainly can be still until you've had that 12 consecutive months without a period.
Mm-hmm.
The heavy bleeding that we can see with perimenopause is generally because we may not be ovulating as regularly. So estrogen is the hormone that drives the thickening of the lining of the uterus. This is called the endometrium, or the endometrial lining. Estrogen makes it grow, so it becomes this big, squishy place for a fertilized egg to nestle in, because we know the reason we have periods is to make a baby. Now, in the 21st century world, we don't necessarily want to make babies all the time, but physiologically, this is how babies are made. So this happens month after month after month, so we can get pregnant if all of the the variables are in line. So estrogen causes the lining of the uterus to thicken. Progesterone is secreted after the egg pops out of the follicle after ovulation. And then we make progesterone for the second 2 weeks. Once the progesterone levels drop, we bleed. That's a period. That's one cycle. What can happen in perimenopause is we don't always ovulate. You might still bleed every month, but ovulation starts to slow. And that's because we're born, interestingly, with all the eggs we're going to have for our whole life. So they start to get fewer as we age, and the body always trying to pick the healthiest egg. And so because we're exposed to chemicals, plastics, all the things in the 21st century planet that could potentially be toxic, by the time we're aging into our 30s and definitely our 40s, fewer of those eggs are viable. So sometimes we can have estrogen being secreted without ovulation. If we don't ovulate, we don't make progesterone. That means that thick uterine lining can continue to build up for longer than it might otherwise. This can result in very heavy bleeding. So, and I know that was a very wordy explanation for this, but if you're one of those women who starts to notice that your periods are becoming much, much heavier, And sometimes it can also be accompanied by an increase in the pain that you feel. It probably is an indication that you're not ovulating as regularly anymore, which is a sign of perimenopause. Another really common symptom is hot flashes and night sweats. These are also called vasomotor symptoms or VMS. Sometimes you'll see that term thrown around. So that's what we mean. Vasomotor symptoms are hot flashes and night sweats. These are really common during perimenopause. Now, the intensity and the length and the frequency will vary depending on the woman. Sometimes it's just sort of a slow burn. Sometimes women feel so hot that they're literally drenched in sweat, and they can happen once a day, they can happen once an hour, they can happen once every 10 minutes. When they happen at night, they're called night sweats, and that can interrupt our sleep. Sleep can become unpredictable in perimenopause, even if we aren't having night sweats, but certainly if we are having night sweats, that can be a big reason why women stop sleeping as well. Another thing that can happen in perimenopause is mood changes, mood swings, irritability, maybe even an increased risk of depression and anxiety. There are a lot of reasons this could happen. One of them is that if we're not sleeping as well, we're going to be grumpy. We're having those hot flashes that interrupt our sleep, or if we're just not sleeping as well for whatever reason, this can definitely make those mood swings feel a lot more disruptive to our days. Now, think back to what you might have experienced in if you had PMS during your peak cycling years. If you had a lot of mood swings associated with PMS, the likelihood of you having mood swings in perimenopause is pretty high. Some women can swing from high to low during menopause, thanks to those hormone changes. So, just pay attention to that. Again, if you have a history of anxiety or depression, you may be at greater risk of these getting worse during perimenopause because those changes in estrogen and progesterone make you more vulnerable. Everybody probably is familiar with the symptoms of depression, but it might look like feeling hopeless or worthless. It's not necessarily feeling sad. Sometimes it just is sort of a feeling of apathy, a feeling of not being enough. Sometimes you'll feel numb. Maybe you cry a lot. Maybe you find you can't cry at all. Often what we see is just a loss of interest in the things that used to bring us joy. Anxiety is kind of the flip side to that. You can have depression and anxiety, but sometimes we experience one or the other. Anxiety generally manifests as constant worry. It can get in the way of your day-to-day life. So you can feel it in your body. Sometimes it feels like heart palpitations or muscle tension or even sweating or nausea. But both depression and anxiety can make it hard to concentrate, hard to sleep, and hard to take care of yourself. Some other symptoms we might see are vaginal and bladder problems. So as our estrogen levels diminish, the vaginal tissues can lose lubrication and elasticity, and they can become thinner and drier. This can make sexual intercourse painful, and that can affect your libido. Low estrogen can also leave you more vulnerable to urinary tract infections or vaginal infections. And loss of tissue tone because of that loss of estrogen can potentially contribute to urinary incontinence, especially maybe if it's a stress incontinence because of multiple pregnancies. That low libido that's associated with vaginal dryness can result in changes in sexual function. So you may notice that you're not as interested in having sex with your partner. And this is usually we're talking about penetrative sex, whether you're a heterosexual or homosexual couple. But any touching of those tissues can be uncomfortable because, again, as estrogen levels drop, those tissues can become more sensitive, more irritated, more friable. So if it's uncomfortable to have intercourse, your desire for sex may also change. If you had satisfactory sexual intimacy before menopause and you want to continue it through perimenopause and beyond, it's not the end of the world. There are a lot of things that can be done to protect this. We can talk about this later, EJ, but hormone therapy, there are also a lot of over-the-counter lubricants and moisturizers. Any of us allows us to feel powerful and in control and connected with our partners. So if your perimenopause is affecting your sexual health, you probably want to talk to your doctor about it. Don't suffer in silence. Another thing that we can experience in perimenopause are cognitive changes. You may hear this called brain fog. It might be forgetfulness. Essentially, these changes in hormones make it a little bit harder to remember things. So you might find you're losing your keys more often. Maybe you're forgetting appointment times. Maybe you're having trouble focusing. This is a pretty common symptom. We might notice we have less hair on our heads and more hair where we don't want it. Maybe you've got hair popping out on your face or popping out on your belly. That's called hirsutism. This is actually often testosterone that drives this, but also associated with perimenopause. You might also see an increase in acne. Maybe you had acne as a teen and you haven't had it for decades, but suddenly you're noticing acne again. It's so annoying.
So, so annoying.
And belly fat. That fat around the middle, that we call it male pattern or that androgen pattern, that fat that's really hard to lose, that can be associated with perimenopause. I do want to mention two medical issues that can begin sort of developing and growing during perimenopause. One is bone loss, because as estrogen levels start to fall, many women start to lose bone more quickly than they replace it. And so this can lead to osteopenia and then osteoporosis. This is a disease that causes fragile bones. And we know that when elderly women fall, they're more likely to fracture, usually a hip. And then the increase in mortality rates once a woman has fractured a hip are significant. So this is the time in our lives to make sure that we are getting calcium and we're getting good support for hormones, and that we're getting good weight-bearing exercise, because it's that sort of pounding your feet on the pavement or doing some strength training that can help to ensure that our bones stay dense. The other thing to keep an eye on is changing cholesterol levels, because as our estrogen levels start to drop, we can start to see unfavorable changes in our cholesterol. So what this looks like often is an increase in the LDL, that's considered the bad cholesterol, and a decrease in the HDL, which is considered the good cholesterol. Changes like this could potentially increase the risk of heart disease, cardiovascular disease, which is the #1 killer of males and females worldwide. So definitely something to keep an eye on. So, that's sort of the short list, even though I know that list is not short. But those are the things that women would probably begin to notice during the perimenopausal transition.
Yeah, I think it's important to take away that there's no one same experience. Everybody has their unique experience, but there are all kinds of symptoms that you need to pay attention to, and the ones that you mentioned are some of the key sort of symptoms that we will experience. Are there any tests? And I think that's the thing, everybody sort of want that kind of real clarity, like, am I or am I not? And that leads to like, what can I do to like test myself, or what kind of tests should I even ask my doctor to do? So what will be your sort of advice when it comes to testing perimenopause? Is it even something that you test?
It's a really important question. And unfortunately, like so many things, when we discuss perimenopause, there's really no clear answer. And I think that contributes to some of the misunderstanding and lack of education about perimenopause. So to date, there really is no simple test to predict or to confirm menopause or perimenopause, because this is typically a gradual transition. So no, there's not one test that's going to give you a definitive answer. Generally, what happens is you'll talk to your doctor, and often this can be your gynecologist or your primary care doctor. What they're likely going to do is take a thorough history, who you are as a person overall, but also they'll talk about your menstrual history. They'll talk about history of pregnancies. They may even ask you the age you started your period, the age your mothers and aunts and maternal grandmother reached menopause, because there does seem to be a genetic component in that way. They'll probably ask you about your symptoms and the severity of those symptoms. So this information generally is what we work with to try to determine if a woman is in perimenopause. There are some tests I think are worth doing. One is thyroid testing. You always want to make sure your thyroid is functioning properly. The thyroid really drives our metabolism and our energy. And so as we start to feel sluggish and trouble focusing and mood swings and changes in temperature, the thyroid can certainly play a role. So we want to make sure we've got optimal thyroid function. There is a test that if you have ever on Amazon or at the pharmacy in your neighborhood, if you've seen a menopause predictor kit on the shelf, what those are doing is testing FSH, follicle stimulating hormone. So FSH is a hormone that's produced by your pituitary gland. FSH levels increase temporarily each month because that's the signaling hormone that tells your ovaries that it's time to produce eggs. When you enter menopause, we know that ovaries stop working. So what happens is FSH levels start to increase because the ovaries aren't responding. So think of it maybe like a person yelling to be heard. If I'm trying to talk to you, EJ, and you don't hear me, I'm going to talk louder. I'm going to yell louder until you hear what I'm saying. So as the ovaries stop responding to FSH, the pituitary yells louder.
Wow.
It secretes more and more FSH to try to get those ovaries to respond. So this is what these kits are testing. Your doctor can do it too. The kits at the pharmacy are typically urine. Your doctor may also test in urine, but you can also test in blood. So these menopause predictor kits are looking at FSH levels. And what they're saying is that if you find elevated FSH levels, it could be a sign that a woman is moving towards or has reached menopause. Here's the problem. It's not as straightforward as it might sound. A single FSH level can be misleading. In perimenopause, our hormones are sort of doing this all day. They fluctuate. Hormones are secreted in pulses anyway. It's not like you turn on your garden hose and you have this steady stream of hormones coming out. It's like, right? These glands just sort of puff out hormones throughout the day. And so that's normally what happens. And then in perimenopause, it's like nuts. It just starts to get so unpredictable and so erratic. So catching an FSH level or just having one really gives you nothing to work with because you could have caught it here or here. It's very difficult to know how that is actually representative of the woman. So definitely if you're doing an FSH kit, don't just test once because that does not confirm menopause. I want to make sure that everybody understands finding low FSH in a woman who's having hot flashes and her periods have begun to change. It doesn't eliminate the likelihood of her being in perimenopause. And conversely, if FSH is elevated and she doesn't have symptoms, it doesn't mean she's menopausal, right? This is just a clue. There's some things also that can affect FSH and kind of make the findings less reliable. Things like birth control pills can actually affect the way FSH is secreted. And so that would be a reason why maybe this wouldn't be a reliable test for you. So, you know, I think doing a test like this can sometimes make us feel better because it's like, oh my gosh, I'm not crazy. There's a real physiological reason why I'm feeling this way. The problem is that it's not going to give you a definitive answer. So again, a positive test result indicates you may be in perimenopause, but it's not definitive. Again, please don't stop using contraception based on one of these kits because you could still be fertile. And then on the flip side, if you have a negative test result, but you're experiencing symptoms, you might be in perimenopause after all. So I would say use these with caution.
Mm-hmm.
And if you do have an FSH level or a series of FSH levels, which is more reliable, you definitely always want to take that information into account and also think about the symptoms you're experiencing. Also think about the age of your familial line of women when they may be transitioned into menopause and that sort of thing.
Wow, that's great. Thank you. Because I think now we hear a bit more about sort of self-test kits. And I personally have seen some ads and I'm like, I'm not sure what to do with it. And I actually do follow some of the conversations and women were like, well, like reacting to some of these numbers, but to your point, like it has to be really super holistic. And that's, I want to ask you about how should women, I mean, they can help themselves and take doing the test at home. But in terms of having conversation with doctors, doctors, what advice do you have for women in perimenopause? How to best have this conversation with doctors, how to approach this?
Um, so you need to be a strong advocate for yourself. I'll say that first. So if you're having symptoms that are interfering with your life, your well-being, if you're having hot flashes and mood swings and changes in sexual functions, any of these symptoms we've discussed or anything else that just feels weird to you, you don't quite feel yourself, talk to your doctor. I think it can be really helpful if you keep a diary, whether it's in a journal or a note app on your phone. Keep track of your changes in menstrual cycles. If you have a period app, that makes it really convenient to chart cycling, but you're also going to want to keep track of any new symptoms that appear. If it's a physical symptom or a psychological symptom. So if you're starting to feel more moody, write it down. If you notice changes in sexual response, write it down. Keep track of all of these things, because then you won't forget to tell your doctor. Because let me tell you, because cognitive changes is one of these symptoms, and I speak from experience, you'll find yourself sitting in front of your doctor and she'll say, "Tell me what's going on." And you're like, "Oh my God, there's like so much and I can't think of a single thing." So write it all down and then you can just go through your list together. And again, you may have to advocate for yourself, because the truth is, perimenopause is not taught in medical school. It's a nuanced thing. It's something I think as Gen X is moving into this change, we're starting to realize it's okay to talk about it, and it's okay to educate our sisters about it, because we're all in it together, right? Women are half the population of the earth. We're the mothers and the caregivers and the daughters, and we run corporations and we run families. So we have to be healthy and we have to be feeling good. So I think we have to advocate for ourselves to make sure that we're going to be able to get the support that we need. So if you feel like the changes you've noticed in your health correspond to changes you've noticed in your menstrual cycle, tell your doctor and stress this point, because that might help her feel more motivated to go down this perimenopausal path with you. You are the most knowledgeable person about what's real for you. So don't let your doctor tell you it's all in your head. It isn't. If she tells you that, you probably need to find a new doctor.
Yeah. That's a good advice. I think sometimes women kind of don't know, and that's also why we actually put together ultimate sort of guide to perimenopause, a conversation with your doctor. So we have a sort of cheat sheet available.
Yeah.
Because women are having hard time, like, showing up, and yeah, so that was the definitely something that we looked into. So last question. Want to talk a little bit more about what are the things that we can do. Of course, there's a testing, but what are the sort of ways that we can help ourselves in perimenopause? That includes a lifestyle adjustment as well, but I would love for you to kind of help us understand, what can we do?
Yeah. The first thing I would do is talk to your doctor about your options. So is hormone replacement therapy an option for you? If mood changes in particular are interfering with your ability to participate in your life, you might consider antidepressants, at least for a period of time. Um, but there are a lot of herbal and dietary supplements too that could be an option. And if you're seeing a functional medicine provider or a naturopathic doc like me, we may also do other tests like we want to try to help you optimize your health. So we might test your gastrointestinal tract. We might test do an expanded cardiovascular profile to make sure we know really, all the different things that might be reflective of cardiovascular health. We'll test your microbiome. We'll do nutrient testing, maybe even genetic testing. So that can help functional docs choose what therapies are right for you. But in terms of what can you do yourself in your own home, one of the most important things that drives poor health is chronic inflammation. Chronic inflammation is going to make any symptoms you're experiencing worse. And one of the most common reasons that women in North America are inflamed is that we eat a poor diet. So you may sometimes hear the term the standard American diet or the SAD. what we're talking about here is really diets that are high in saturated fat, simple carbohydrates, sugar, alcohol, processed food. So that's fast food, that's frozen pizzas, that's lean cuisines, or that's even just like chips, white bread, white pasta, white rice. If we eat a healthy diet, that's a really simple way to reduce a persistent source of inflammation. And an excellent diet to follow is the Mediterranean diet. And you can Google that if you want to know exactly what it means. But it's essentially fish, lean meats, lots of vegetables and fruits, but also taking time to slow down and enjoy food with friends, with people who make you happy, because trying to cultivate that joy, interestingly, can lower inflammation. It's really important. You really want to prioritize sleep. If you're not sleeping, your health will suffer. Your symptoms will be more severe. So maybe EJ and I can have a future conversation about how to improve sleep if you've got insomnia, because it's a pretty complicated issue. But you definitely want to make sure that your room is dark, your room is cool, that there are not a lot of sounds in the room. You've probably heard the term sleep hygiene. This is what we're talking about. Not looking at screens and the hour or two before bed. You want to try to make your sleeping space very conducive to a good night's sleep. But if you are having hot flashes, if that's one reason why you're not sleeping at night, those night sweats, here's some tips. Dress in layers that can be peeled off. Actually, these are tips for hot flashes and night sweats, not just sleeping. So when you're walking out in the world, dress in layers, because like I mentioned, I'm now perimenopausal myself. I don't ever wear just a long sleeve anymore because I have found myself trapped in my hot flash in a social situation, and it's horrible. So I like to be able to peel off my sleeves and have a short sleeve shirt underneath. Wearing natural breathable fabrics is really helpful. So cotton and linen are good options. You want to avoid silk, synthetic fabrics, and maybe wool. Loose fitting clothing, maybe clothing with an open neck, so turtlenecks will probably be off limits for a while. You could keep cool beverages nearby. You're going to want to lower the thermostat whenever you can. And if you can't, just have a fan or maybe even a battery operated fan nearby. At night, you can wear cotton PJs or nightgowns to bed. Some people like to sleep naked, and that's fine. But if you do have a lot of night sweats, it can be easier to just take off those pajamas or nightgown rather than change the whole sheets, depending on how severe the sweats are. But if you do prefer to sleep nude, what you might do is put several fitted sheets on the bed so that if you sweat through the top layer, you just pull it off, but the second layer is on there and it's ready to go. Make sure those sheets are cotton. If your partner is making you feel hot, maybe invest in a bigger bed if that's possible. You could also take a cool shower before bed. That can sometimes help to keep those hot flashes at bay. So prioritize sleep. Absolutely. And if any of those things are making your hot flashes worse, those are some tricks. You're definitely going to also want to try to have regular exercise, both aerobic and strength training. If you're overweight, try to lose some of those pounds. Much easier said than done. I completely understand that. But excess fatty tissue can drive inflammation and make a lot of these symptoms a little bit harder on us. Limit caffeine, sugar, and alcohol whenever you can. And if you're a smoker, try to quit. Smoking actually will speed up the menopausal transition by about 2 years. So if you can quit smoking, that might help this transition be a little bit more predictable, not speed things up so much. And then anything that can reduce stress is really, really helpful. So there's so many options. Pick the one that's right for you. Maybe meditation, deep breathing. There's some really great apps out there. If you've tried meditation and your mind just races and you think it's not for you, you could try these apps because they're made for us to be successful. These people have soft voices and there's this soft music, and it really does help with relaxation. Yoga is great. Listening to music, writing in a journal, getting a massage, all of these things can help to promote our parasympathetic nervous system and squash our sympathetic nervous system, which helps us relax and feel a lot better. And again, back to that vaginal dryness piece and painful intercourse, you could talk to your doc about HRT options, but there are a lot of over-the-counter vaginal lubricants and moisturizers that can help with that. So there's no need for you to suffer in silence.
No, thank you so much. And the last words from you for those who are looking into HRT in perimenopause, what advice do you have for them?
Oh gosh, it's a really complicated topic. Maybe we can do another interview in the future, but I'll just say this. The Women's Health Initiative, which was published in 2002, made hormones seem really, really scary. Um, and some of you watching may remember this study because it essentially has resulted in a whole generation of women not getting HRT, which can be really beneficial. The challenge with hormone replacement therapy is that it comes in all shapes and sizes, and some forms of HRT have been shown to be potentially harmful, and some forms of HRT have been shown to be really beneficial and pretty safe. So, the issue with the Women's Health Initiative, well, the issues were multiple, but in short, the arm that was stopped early because the risk of stroke outweighed all the other benefits they were looking for was the arm with women who were taking oral conjugated equine estrogens paired with a synthetic progestin called medroxyprogesterone acetate. Primpro was the trade name. Two things wrong with this mixture. The estrogen is made from pregnant horse urine, and also it's swallowed. And swallowing estrogens is not the best way to take them. When you swallow estrogens, they can increase inflammation in your body and also increase the risk of clotting. So that alone can increase the risk of stroke. Then the addition of the synthetic progestins not only increase the risk of stroke, but also increase the risk of breast cancer. There was an estrogen only arm of the Women's Health Initiative. Those findings weren't published in 2002. The 2002 findings of that Primpro arm were really alarming, and that made all the headlines. The media didn't publish the estrogen only arm study, which I think came out in about 2007. And essentially, they found that for the women taking estrogen only, they actually were doing pretty well. And then subsequent studies over the last 2 decades have found that if you use natural progesterone versus the progestins, that's more protective and good for our health. And if we use transdermal estradiol in its bioidentical form rather than swallowing it, that's also really, really beneficial for our health. And that can not only help to control all the symptoms we talked about today, but also prevent the development of osteoporosis, breast cancer, Alzheimer's disease, and cardiovascular disease. So I'm a big proponent of HRT if it's done correctly. And so talk to your doctor about it. There are a lot of options out there. Not all doctors are as comfortable with HRT as I wish they were, because I think they're still relying on some of the fear associated with those women, the initial Women's Health Initiative findings that were published so long ago. But we know better now that when done correctly, HRT can be really valuable to help women feel like themselves again, and then prevent the development of some of those diseases that are typically worse in menopause.
No, so thank you. That was a loaded question. And I think we can do a deep dive into this, maybe perhaps the next segment. But there's a lot of questions about natural versus HRT as if people have to choose only one way of dealing with it, which is not true either.
Yeah.
So there's definitely different ways that we can help women understand different options and plus and minuses. So I think that could be something we can talk about. But today, this was amazing. Thank you so much. I think that everybody probably walk away at least knowing the very much how peri is not menopause. And there are a lot of different things that we can do on a day-to-day basis. So you can actually take control of how you feel and being able to manage a bit better. So thank you so much, Dr. Ferris, and hope to see you again soon.
Yeah. I'm so happy to be with you, EJ. Thanks for having me.
Thank you. And I'm going to start.